Abdominal trauma. The objectives of this lecture are to identify the anatomic regions of the abdomen, the mechanisms of injury in abdominal trauma, which are blunt and penetrating, clinical signs of injury in the different anatomic regions, diagnostic procedures that we do in abdominal trauma, and treatment modalities available. Abdominal trauma is challenging because it's often a common cause of preventable death, and it has subtle symptoms and subtle signs, so that it's difficult to identify early, especially in the multiple injury patient. So we should have a high index of suspicion when you have a multiple injury patient or when you have a patient with significant tarsal trauma. The external anatomy of the abdomen, we have got the thoracic abdomen, the true abdomen, the flanks, the back, and the pelvis. The thoracic abdomen is those abdominal organs that are usually within the thoracic cavity, that is below the diaphragm, like the liver, the spleen, and stomach as well. In maximum expiration, the diaphragm can reach the level of the fourth intercostal space. So they can be injured in thoracic injuries as well. The flank area is defined as shown by the bold line, 6th intercostal space above, iliac crest below, and anterior and posterior axillary lines on the flanks. And the back is defined again by the tips of the pillar, the iliac crest, and the posterior axillary line. And this is an area that is usually occupied by the vertebra and the muscles of the back, and relatively well protected. When you look at the internal anatomy of the abdomen, we have the retroperitoneal space, where we have the great vessels, the aorta, the inferior vena cava, the pancreas, kidneys, ureter, and part of the duodenum. In the peritoneal cavity, we have the diaphragm, the liver, spleen, and stomach, and the intestines. And in the pelvic region, we have the iliac vessels, we have the rectum and bladder, the uterus, and the ovaries in the female. Mechanisms of injury. In blunt trauma, these are the mechanisms of injury we could have. One is crush or compression, which can injure solid organs, but can also injure gut. Closed loop, where part of the gut can act as a balloon because of the air in the gut. Then deceleration injury can usually tear organs at their point of attachment. For example, the intestines attached to the mesentery, or the kidneys at the pedicles, or other organs. The mechanisms of injury in penetrating injury are, for example, stab wounds and gunshot wounds. In stab wounds, the injuries will affect contiguous structures, but this may vary depending on the anatomy. They're much easier to predict when you have the liver, the small gut, diaphragm, colon, or retroperitoneum. In the retroperitoneal space, then we can be able to identify possible injuries. And in gunshot wounds, but depend whether on their high velocity or low velocity injuries, and the trajectory will be different from stab wounds in that it's variable. And what causes injury is the transfer of energy from the bullet, and sometimes, especially for high velocity injuries, structures can be injured far from the track of injury. And sometimes also when they strike bone or other tissues, they generate secondary missiles which can cause further injury. Commonly injured structures are the small bowel or colon, the liver, the blood vessels, or structures in the retroperitoneal space. How do we assess a patient with abdominal injury? Again, as always, we start with the primary survey, and our focus is mainly on circulation because it's one that's most affected in abdominal trauma. And we need to determine whether it's necessary to do an emergency laparotomy, and this is determined by hemodynamic instability, peritonitis, evisceration, that is a protrusion of gut from any open wounds in the abdomen, free air under the diaphragm suggesting gut injury, transabdominal missile injury. Any penetrating abdominal injury will warrant laparotomy. Sometimes the only symptom might be bright red blood per rectum or in the NG tube, both suggesting injury to this organ. In the secondary survey, we need to determine the history, and in the history what we are interested in is something to help us understand the mechanism of injury, and then we evaluate the entire abdomen, the back, the flank, and we assess for lacerations or bruises, and a rectal exam is mandatory as well. Signs and symptoms of abdominal injury. On inspection, we must first of all expose the patient. Log rolling is also important to identify injuries to the flank and the back. We check for external signs of injury, any abrasions, lacerations, or contusion, any evisceration of gut or distension, and sometimes the distension may be from pregnancy, from obesity, from ascites. We have to establish that as well. We check for the abdominal movement with respiration. This normally suggests that abdominal muscles are relaxed. And we check for obvious masses or swellings. We then palpate the abdomen, and in palpation we want to check for any rays of tenderness, whether the patient is guarding, that is, whether the abdominal muscles are rigid, and whether that guarding is voluntary. Occurs when you palpate, and this is an unreliable sign. When it is involuntary, that is, the abdomen is tense throughout, then it could be a sign of peritoneal irritation, and that needs further evaluation. And rigidity is when the abdomen is hard like a board and no movement with respiration. We also check for rebound tenderness, which suggests peritoneal irritation. And we should not forget to check for pelvic stability by applying compressive forces on the iliac crest and on the pubic symphysis. And we don't expect any movement, so if these points move, then it suggests that pelvis is unstable. And about 50% of abdominal injuries are associated with a pelvic fracture. That is quite a big percentage. Then also must evaluate for genital and rectal injuries. In the urethra, first thing to check is of course whether there is blood at the urethral meatus. In the rectum, we do digital exam to check for a high riding prostate. We check for any urethral injury. High riding prostate suggests that there is urethral injury, maybe transection, and we check for blood in the gut, and we feel for any obvious injuries which you might palpate. We check for sphincter tone, and this helps us to rule out a vertebral injury or a spinal injury. And this is necessary before we do a urethral catheterization, and we also need to put NG tube. The urethral catheter will give us urine, and this urine we check whether there is any blood in it, and if there is blood, it suggests injury either in the kidneys, the ureter, or in the bladder itself. And the NG tube also to check for blood from the stomach and to decompress the stomach.